Hello students, as we have already discussed the staging of carcinoma esophagus, now we will come to the treatment. Once you stage carcinoma esophagus, you can treat the carcinoma esophagus. What are our treatment options? Our treatment options in carcinoma esophagus include chemotherapy, radiotherapy and surgery, the knife. Chemotherapy, the poison, the radiotherapy, the fire, the radiation. So, with these pictures in mind, we will discuss regarding the different treatment options of carcinoma esophagus. Now, the treatment of carcinoma esophagus depend not only upon the staging of the carcinoma esophagus, it also depends upon the primary tumor of the esophagus, the lymph node, both local and regional, whether there is a distant disease, and also the patient condition, whether the patient will be able to tolerate the surgery, and the goals of the treatment. We will come to it. Now, regarding the primary tumor, we should always take all these factors into consideration. Now, coming to the primary tumor. In primary tumor, we have to consider the histology of the tumor, the location of the tumor, and the extent of the tumor. But regarding histology, whether it is a squamous cell carcinoma or an adenocarcinoma. Regarding the location, whether it is in the upper esophagus, or it is in the middle esophagus, or is it in the lower esophagus. Regarding the extent, whether it is T1, T2, T3 and or T4 lesions. So, you see that all these things has to be taken into consideration. So, how will we take this into consideration? Regarding the squamous cell carcinoma, you see the squamous cell carcinoma is amenable to chemotherapy and radiotherapy. Whereas it is also surgically amenable, but it is very much amenable to chemotherapy and radiotherapy. It is treatable with chemotherapy and radiotherapy to a certain extent. We can reduce the size of squamous cell carcinoma before surgery in case with the help of chemoradiation. So, if it is a squamous cell carcinoma, we will give weightage to chemoradiation rather than surgery. So, chemoradiation has a predominant role in the treatment of squamous cell carcinoma in esophagus. Suppose it is an adenocarcinoma, there is no role for chemoradiation. The adenocarcinoma is not at all responsive for chemoradiation. So surgery, whatever may be the carcinoma, if it is adenocarcinoma, surgery is the mainstay of treatment in carcinoma esophagus, in adenocarcinoma. Now coming to the location of the tumor. If it is in the upper esophagus, it is in the anatomical jungle, in the neck. So the chance for invasion of the surrounding structures is very high. The chance for invasion to the larynx is very high, to the trachea is very high. So if it is in the upper esophagus, chemoradiation is more preferable than surgery in the upper esophagus initially, then it can be followed by surgery. First approach is chemoradiation. If it is in the mid esophagus, there is a lot of space, you can approach very well, surgery is the mainstay of treatment. Lower esophagus, very often, again surgery is the mainstay of treatment in the lower esophagus. Suppose the lesion is T1. Earlier the lesion, you take it out by surgery. Don't wait for it to spread. Don't keep the lesion there. So, regarding the extent of the lesion, if it is a T1 lesion, surgery is the mainstay of treatment. If it is a T2 lesion, what to do first? Whether we should go for a chemotherapy first, reduce the size, and then go for surgery, or first we should go for a surgery and then after that go for a chemoradiation. This is always debatable in T2 lesions, but evidence suggests that you can go either way, but many people prefer surgery first. Whereas in case of T3 lesion, the weightage goes more in for the chemoradiation first, then surgery. First we will do chemoradiation, downstage the tumor, reduce the size of the tumor, decrease the infiltration of tumor, and then go for a surgery. Neoadjuvant chemotherapy first, and then for a surgery. In case of a T4 lesion, the primary treatment is mainly chemoradiation followed by a palliative surgery, or if a definitive surgery is possible, then a definitive surgery. Now, coming to the lymph node involvement. Lymph node involvement, it can be an N0 lymph node or an N1 lymph node. If it is an N0 lymph node, you can see the upper esophagus, the drainage into the cervical lymph nodes, the mid esophagus drains into the mediastinal and the thoracic nodes, and the lower esophagus drains into the lymph nodes locally. Suppose the lymph node involvement of the cervical esophagus, there is no lymph node involvement, it is called N0. But if the lymph node involvement is cervical lymph node involvement, it is N0. It is N1. If there is cervical lymph node involvement, it is N1. In case of thoracic lymph node involvement, if there is a mediastinal lymph node involvement, it is again N1. If there is abdominal, if it is a lower esophageal tumor, and if there is an involvement of the lymph node in the abdomen, it is an N1. But suppose there is a cervical tumor, cervical esophageal tumor, and there is an involvement of a node in the abdomen, it is not considered as N1, but it is considered a distant disease. So you know now what is N1 and what is distant disease. So same lymph node, a lymph node in the abdomen can act as an N1 if the location of the tumor is in the lower esophagus, and if the location of the tumor is in the cervical esophagus, the same node in the abdomen will act as a distant disease or M1. So, suppose the lesion is an N0 lesion, the mainstay of management is surgery. It has not spread anywhere. Suppose the lesion is an N1 lesion, the first line of treatment is a chemoradiation, reduce the size, and then go for a surgery. In case of a distant disease, the primary role is for a chemoradiation. You reduce the size, and then you decrease the metastasis. The role for surgery is only a palliative. There is only a palliative role for surgery. Now coming to the condition of the patient. Should we operate this patient? This patient is old, this patient is debilitated. Should we operate this patient? There is no actual contraindication for surgery per se. But if the patient is debilitated and old, you should consider improving the nutritional status of the patient first and then go for a surgery, because it really helps in the post-operative improvement and the post-operative morbidity and mortality of the patient. Sometimes you can go for a feeding jejunostomy or an esophageal stent to improve the condition of the patient, to improve the nutrition of the patient. Now, what is the goal of the treatment? In all patients, we cannot cure all patients with esophageal cancer. Especially in advanced stages, there is no role for curative treatment. So, what line of management are you considering the patient? Is it a curative line or is it a palliative line? In a curative line, if it is an early stage, if it is a young patient, if the patient has a good nutritional status, and if there are no vital structures are involved, our mainstay of management will be a curative. If the management is a palliative, if the management is a curative type of management, we will consider more of an aggressive surgery followed by chemotherapy. So, suppose if the lesion is, we are considering a palliative treatment, especially in late patients, if it is in a late stage, in old age patients, poor nutrition and distant disease, we shall consider. There is role for surgery in case of improving the nutrition, but we will go for a less surgical methods of chemoradiation in palliative treatment first, and then after that only surgery. So that is regarding the condition of the patient, regarding the curative goals, what is the goals of the treatment and the approach of the patient. Now the stage-wise distribution of the treatment. So suppose the lesion is a stage 1 lesion or a T1. So suppose the lesion is a T1 stage 1 lesion, that is T1N0 lesion, we will consider surgery is the mainstay of management. In rest all other stages, it is a blur. Okay? Suppose it is a T2 lesion with an N1, some consider that you could go for chemoradiation first, some consider that you should go for a surgery first. Suppose it is a T3 N0 lesion, some of the surgeons consider go for a chemoradiation. Less aggressive conservative surgeon says you should go for a chemoradiation, decrease the size, and then we will do a surgery. And very aggressive surgeons will say we will go for a surgery first, and after that we will go for a chemoradiation. So all these factors come into play. So when we see a patient with carcinoma esophagus, you stage the disease, then you take into the consideration the different parts we have already discussed, the condition of the patient, the TNM stage, then the condition of the patient and the goals of therapy before deciding whether you have to go for a surgery or not, or whether you have to go for a chemoradiation first or not.